Hello, first of all, I would like to thank the scientific committee for selecting this abstract to be presented as an oral presentation at San Antonio Breast Cancer Symposium 2021. On behalf of my co-authors, I am pleased to review the PD-L1 CPS subgroup analysis results from Keynote 355. These are my disclosures. Pembro monotherapy showed durable anti-tumor activity and manageable safety in patients with metastatic triple-negative breast cancer. Several clinical trials in early triple-negative breast cancer show that combination regimens with pembro plus chemo provide anti-tumor activity and manageable safety. After prior results showed increased PCR rates with pembro plus chemo, the phase 3 Keynote 522 study showed a statistically significant and clinically meaningful improvement in event-free survival with neoadjuvant pembro plus chemo, followed by adjuvant pembro versus neoadjuvant chemo alone. The Keynote 355 study showed that pembro plus chemo resulted in statistically significant improvements in PFS and overall survival compared with chemo alone for the first-line treatment of metastatic triple-negative breast cancer in patients whose tumors express PD-L1 with a combined positive score, CPS, of 10 or more. No statistically significant benefit for PFS or overall survival was seen in the CPS 1 or more population, and the benefit was not tested in the intention to treat population due to the pre-specified testing strategy. In Keynote 355, patients with de novo metastatic triple-negative breast cancer or a disease-free interval of at least 6 months after the end of neoadjuvant or adjuvant chemo for early disease were randomized 2-to-1 to pembro chemo, nab-paclitaxel, paclitaxel or carbogem, or placebo plus chemo. Pembro or placebo was given up to 35 administrations. Chemo was administered according to the local guidelines in an open-label way. Stratification factors were type of on-study chemotherapy, tumor PD-L1 expression at baseline, and prior treatment with the same class of chemo in the neoadjuvant or adjuvant setting, yes or no. Two primary endpoints, PFS and overall survival, based on the blinded independent central review, CPS 10 or more, CPS 1 or more, and in intention to treat populations. Secondary endpoints include overall response rate, duration of response, disease control rate, and safety. In the present analysis, we assessed outcomes in subgroups of patients by additional CPS cutoffs. Here you can see the treatment disposition of all randomized patients. A total of 847 patients were randomly allocated to pembro chemo 566 or placebo chemo 281. Median follow-up was in range of 44 months. PD-L1 expression was well balanced between the two treatment groups. About 25% of patients did have CPS less than 1, 37% had CPS 1 to 9, 14% 10 to 19, and 24% 20 or more. Baseline characteristics were as expected and well balanced between the two treatment groups. Median age was 53 years. About 55% of patients received carbogem in the study and 45% received taxanes. 30% did have de novo metastatic disease, 20% had a disease-free interval of less than 12 months, and 50% 12 months or more. As previously shown, here are the primary overall survival results at the final analysis. In the CPS 10 or more population, hazard ratio for survival 0.73. According to the pre-specified statistical criterion, pembro plus chemo significantly improved overall survival compared with placebo chemo in patients with CPS 10 or more. In the CPS 1 or more, hazard ratio 0.86, but it did not reach statistical significance. In the intention to treat population, hazard ratio 0.89. Here we see that overall survival was similar in the pembro and placebo treatment groups, in the CPS less than 1, and in the CPS 1 to 9 subgroups. The relative benefit of adding pembro to chemo was the same for the CPS 10 to 19 and CPS 20 or more subgroups, suggesting that CPS 10 is a reasonable cutoff. Here we can see the Kaplan-Meier curves. We see that the curves are overlapping and very similar in the CPS less than 1 subgroup and in the CPS 1 to 9 subgroup. In both populations, median overall survival was similar in the two treatment arms, and the hazard ratios were around 1. In the CPS 10 to 19 subgroup, we see a clear separation of the curves starting at around 10 months, and the hazard ratio was 0.71. CPS 20 or more, same separation of the curves, and the hazard ratio was 0.72. As previously presented, here we see the PFS results at the final analysis. In patients with CPS 10 or more, hazard ratio 0.66. It was 0.75 in CPS 1 or more, and in the intention to treat population, hazard ratio was equal to 0.82. And with overall survival, results for PFS show a trend toward improved efficacy with PD-L1 enrichment with addition of pembrolizumab to chemo. Although the PFS benefit in the pembro arm was slightly greater in the CPS 20 or more subgroup compared to the 10 to 19 subgroup, the difference was very small and the confidence intervals were overlapping. Here are the PFS curves for the additional CPS subgroups, showing a generally consistent trend to that observed for overall survival. In the CPS less than 1 and CPS 1 to 9 subgroups, the curves were overlapping during early time points and began to separate slightly after around 12 months and 8 months, respectively. The hazard ratio was 1.09 for CPS less than 1 and 0.85 in the CPS 1 to 9 subgroup. Median PFS was about 6 months for pembro and placebo in both populations. In the CPS 10 to 19 and CPS 20 or more subgroups, a sustained separation of the curves began at around 4 months, and the hazard ratios were 0.70 and 0.62, respectively. Turning our attention to safety, we see that about 96% of patients in the pembro group and 95% in the placebo group had at least one treatment-related adverse event, including 68% and 67%, respectively, grade 3 to 5 severity. 2 patients in the pembro group died as a consequence of a treatment-related adverse event. Given their mechanism of action, potentially immune-mediated adverse events are of interest in patients treated with immunotherapy. About 26% of patients in the pembro group and 6% in the placebo group had immune-mediated adverse events of any grade. These events were of grade 3 or higher in 5% and 0%, respectively. No patients died as a consequence of an immune-mediated event. In summary, pembro plus chemo resulted in statistically significant and clinically meaningful improvements in progression-free survival and overall survival compared with chemo alone for the first-line treatment of PD-L1 CPS 10 or more metastatic triple-negative breast cancer, meeting the dual primary study endpoints. Given the similar outcomes in the CPS 10 to 19 and CPS 20 or more subgroups, a CPS of 10 or more is a very reasonable cutoff to define the population of patients with metastatic triple-negative breast cancer expected to have treatment benefit from pembro plus chemo. Safety was consistent with the known profiles of each regimen. These results further provide support for pembrolizumab in combination with chemotherapy as a new standard of care treatment regimen for patients with locally recurrent, unresectable, or metastatic triple-negative breast cancer whose tumors express PD-L1 with a CPS 10 or more. Finally, on behalf of my co-authors and the study sponsor, Merck, we would like to thank the patients and their family and caregivers for participating in this study. This study would not have been possible without all of you. Thanks again.